This is Crisis Point. We spoke with 3 expert clinicians on this major public health burden and the efforts to reduce these health disparities. There are pronounced racial and socioeconomic disparities in the prevalence, morbidity, and mortality associated with cardiovascular disease and its various risk factors. Our experts provided insight into the larger scope of these health disparities in connections to biological, environmental, and social determinants of health. An analysis of the Jackson Heart Study revealed the effects of socioeconomic status and food insecurity on cardiovascular disease risk in Black individuals. And finally, our experts spoke at historical factors on discriminatory redlining practices showing higher levels of cardiometabolic risk factors in the modern age, and dedicated efforts to now achieve health equity in these communities.
I think the first thing we need to remember when it comes to disparity, and one of the big areas is race and ethnicity, is that this is a social construct. And so there's not a lot of data to suggest that genetically patients of different race and ethnicity are just more prone to cardiovascular disease. So this is a social construct that we've created in our society, putting certain race and ethnicities and gender into a higher risk for cardiovascular disease.
As many of the individuals watching this will know, redlining occurred in the 1930s. And there were maps that were developed by the Homeowners Loan Corporation in Minnesota. These maps labeled different areas, and the best label was green, but there was green, blue, yellow, and red. And these red areas were areas where it was very difficult to get a mortgage, and lenders did not want to insure mortgages for individuals. Unfortunately, many African American neighborhoods in the United States were color-coded with that red designation. And these are maps from 1936. When we look at them and look at present-day social determinants of health and social vulnerability, what we see is many of these same communities still have high levels of social determinants of health now, and that translates into higher levels of diabetes, both diabetes prevalence, the number of individuals living with diabetes, as well as many of the cardiometabolic risk factors that impact the risk of cardiovascular disease long term. Things like blood pressure and body mass index, as well as smoking. Additionally, when we look at these red line neighborhoods throughout the United States, they have the highest prevalence of stroke, coronary artery disease, and chronic kidney disease. So these maps from over 80 years ago now are really showing us where we have the highest prevalence of cardiometabolic disease today.
So the Jackson Heart Study is the largest longitudinal cardiovascular cohort study of Black Americans in the United States. And it's been ongoing for over 2 decades now. It started back in 2000. And, part of the initial impetus for starting this cohort was the disproportionate burden of cardiovascular disease amongst Black Americans, and the fact that many of the traditional cardiovascular risk factors we think about, in addition to structural factors that impact health, differentially burden Black Americans compared to other groups in the country. Our question specifically was about food access and the risk of developing these outcomes. We know that food inadequacy affects a decent proportion of the US population, upwards of 10%, and that disproportionately affects Black Americans compared to other groups. There's existing data already showing kind of strong associations between limited food access or food insecurity and the prevalence of many cardiovascular comorbidities, hypertension, obesity, diabetes, to name a few.
When we think about social determinants of health, we think about the economic stability of the patient. When somebody is financially limited and they have lower income, they are less likely to develop, less likely to receive financial assistance for housing and a good lifestyle. And this tends to put them at higher risk physiologically as well as physically. And this leads to poor living conditions, unsafe living conditions, and this kind of chronic stress in their body increases their risk of cardiovascular conditions like high blood pressure and diabetes and high cholesterol. Patients that are high risk for cardiovascular disease are those that are have certain elevated risks, right? So these risks would include things like their blood sugar, like their cholesterol, blood pressure management, their smoking status, their physical ability to move around and increase their physical activity, their overall weight and BMI, and the foods that they choose. So these are just like the 7 healthy parameters that American Heart Association says you should concentrate on so that you can prevent heart disease. And so when you look at just these 7 different risks that go into your chance of you developing heart disease, we find just such a massive disparity with just pure race and ethnicity when it comes down to this. So we know that African Americans, Hispanics, and Asians and American Indians, all of these specific races have a much higher risk factor going into heart disease. We know that African Americans have a much higher risk of high blood pressure and specifically high cholesterol. We know that Hispanics have a higher metabolic risk where they have a higher risk of high blood sugar and high cholesterol and overall increased weight and less physical activity. And American Indians also have a higher risk of high blood pressure and diabetes. And Asians have a higher risk of a cholesterol level known as Lp(a), which is unique to their population, which is very arthrogenic. So, just from a risk factor standpoint for heart disease, we know that certain populations compared to Caucasians are much higher. And so because these risk factors are higher, their risk for heart disease is higher.
The primary kind of findings of the study were that worse economic food insecurity, or the presence of economic food insecurity, which actually impacted almost 1/5 of the study sample that we had, was associated with a heightened risk of developing coronary heart disease events and of developing heart failure with reduced ejection fraction in particular over the follow-up period, which was almost 15 years. We did not observe an association with the development of stroke in our study. In contrast, the metric of food access, which was related to number of unfavorable food stores in the area you lived, actually didn't demonstrate strong associations with any of these outcomes. So one of our hypotheses was that individuals who are economically food insecure, that may influence their health behaviors, things like the foods they eat, so their diet. It may influence other health behaviors like physical activity or smoking. And so we repeated the models, further accounting for those things. And that association did not go away. And then our other hypothesis was that economic food insecurity can cause stress. And stress, of course, has been related to allostatic load and higher markers of inflammation. And even after accounting for measures of global stress, we did not see that association attenuate. And so we weren't really able to identify kind of a smoking gun in terms of what's mediating this association, but we do think that this is a robust association that persists after accounting for the things we can think to account for.
One of the first things that we have to do is understand our patients, understand their experience, understand the context in which they live. And we are unable to do that without collecting information on socioeconomic status, non-medical health related social needs, their experiences in the healthcare system. So these pieces are critical to designing interventions to improve health outcomes. And so right now, one of the things across the country is that many institutions are starting to ask the questions around the non-medical health related social needs. Things like food insecurity, housing instability, utilities, etc. And with that, are currently thinking about how do they address these really, really important issues.
And I think most importantly, being a healthcare provider is the healthcare system, and how do we contribute to this disparity as well? There is institutional racism. There's no question about that. There's a lot of implicit bias that is present with physician providers, and that's evident. We don't purposely do it; it's implicit, but it's there, and it comes across in the way that we communicate to our patients, and the language that we use to the patients, in the amount of time that we spend with our patients. And this is unfortunately giving poor quality health care for our patients. There is a major mistrust, I think, with different racial and ethnic groups that lead to poor cardiovascular outcomes because they don't believe that the care that we provide is the best for them. And this goes back to history. I mean, it goes back to even the Tuskegee experiment, which you may be very well aware of, but it goes back to there. And I think that that is one of the things. There's a very limited education to providers as to how to provide culturally competent care. You know, each patient comes from a different culture, comes from different ethnicity, and to provide care that is unique and specific to them, that kind of education is not provided in our routine education to be a doctor. And so I think that's an area that can be an area of focus. So I think that there is institutional racism, and unfortunately, and I think all of this does lead to poor adherence from a patient standpoint to cardiovascular care, and also less trust and overall poor outcomes.
Me, kind of as a clinician, the thing that I take away from this is that, you know, food insecurity and economic food insecurity in particular is not uncommon in the communities we serve. You know, impacts the health of our patients in multiple ways that I don't think we fully understand, but is a risk factor certainly in the cardiovascular space for developing coronary disease events and heart failure, and is therefore something we should know and recognize, because it will influence kind of how we think about that person's risk and how we think about monitoring them moving forward. And so, at least on that level, I know many health systems, ours included, have made a push towards really kind of collecting metrics of social determinants of health, and these measures as kind of metrics that we collect on patients so we can understand the context in which they live. And I think this analysis just highlights that as clinicians, we should pay attention to those, right? That those are actually, I think, very important initiatives that can inform a more holistic view of our patients.
I think that industry, I think pharmaceuticals, I think insurance carriers have too much control over what a patient can receive, despite of what their underlying condition is. And those are not that we're not able to fight at this point in our own space. And so, yeah, there needs to be a change that's much bigger, that puts the patient at the center of their care so that these outcomes can change. Have we noticed change yet? Probably not. I think there's ongoing data every day that comes out from AHA, American Heart, and American College of Cardiology, showing the ongoing disparities and places that things that we need to do. But I think it's still a fairly new area of focus. But I think that there is change going on slowly, and we hope to see that, that we're able to show that with patient outcomes.
So when we think about disparities, it's very easy to look at data and see the disparities that exist, the inequities that exist in our society among different populations, among different groups, In the talk, I talked about racial, ethnic, socioeconomic, urban, rural, and we have the data for all those disparities. What I think has changed over the last 10 years in this conversation is this focus on advancing equity. So it's great to show the disparities, and what I did in my talk was I spent some time showing those disparities, but to really talk about solutions to advance health equity. And I think that that's where many of us in the field are going, putting forward potential solutions to try to identify how in another 10 years there will not be disparities in them anymore, because we've truly addressed equity in the interventions that we're doing and eliminated those disparities that exist.
This has been HCP Live Crisis Point. Thank you for watching.